And I'm sorry for being late, but I couldn't get through customs, and then I couldn't find the taxi, but I'm here now, and I haven't been kidnapped, so that's very important. So this is a very, maybe an older talk, but it's okay. And I think that if you have questions, or if you think I'm talking too fast, make sure you slow me down, because I talk fast, particularly in English and Chinese. So excuse me. So I'm from Calgary, Alberta. I'm from Canada. And if you've never been to Calgary or Canada, it's kind of right here. This is Calgary, Alberta. We're on the west side, so we're beside British Columbia and Vancouver. And we're kind of in the northwest of the city in this area here, where our clinic is associated with the Winsport Center. And the Winsport Center is a center of excellence for winter sports for Canada. In Canada, we don't do any summer sports because it's always snowing. So we only do winter sports. Our summer team is very poor. It's very big, but we never win any medals. But the winter sport is very good. And in this center, we have ski jumping, we have cross-country skiing training, we have big pipe, freestyle, bobsled, luge, and all the gliding sports. We also have the Canadian Sports Hall of Fame, and many of our areas there, the World Cup moguls comes, the Mountain Dew big air comes, and so there are many in-city World Cup events that actually come to Calgary. The clinic is actually right in here, where there are 4 hockey arenas to train, and our center is the Group 23 Sport Medicine, where we have a multidisciplinary clinic, and we take care of pretty much all of the professional and elite athletes in that area. So we're here today, though, to talk about arthroscopic band-cut repair, and we know that as a general statement, most patients do pretty good, but there still is this persistent recurrence rate. And if we look actually at the long-term outcomes of a band-cut repair, in fact, they tend to fail over time. And you can see here in this meta-analysis, at a mean of about 13 years follow-up, the instability rate was somewhere between 15 and 20%, depending on how you define that. Now, you might say that that's actually not that bad. 15% in 15 years, that's not that bad. But when you compare it to a Latarjet or bone block, it's very different. And we know that there are many risk factors that are associated with an increased recurrence rate. Things such as younger age, bone loss, of course, we always talk about, ligamentous laxity, poor tissue quality. All of these things can predispose to a failure of an isolated soft tissue band-cut repair. So the keys to success really for a band-cut repair are, most importantly, the preoperative patient selection, making sure you're doing the right procedure for the right patient. And of course, you have to identify and treat all the pathology as well. I think as a general statement that we always look for a history of traumatic instability and use the physical examination to confirm what type of damage or what type of instability pattern this patient may have. But as a general statement, I don't think it's that confusing per se. The physical examination, of course, you're looking for range of motion strength, but you also want to look for any sort of apprehension in the low position, which usually indicates bone loss, and of course for any posterior instability as well. Diagnostically, of course, we do classic x-rays, but most of us are doing advanced imaging studies, either an MRI arthrogram, looking for particularly soft tissues. But I think if you have any degree of bone loss, while there is some technology now with pretty good bone windows when you're doing MRI, I still think that a CT scan is probably what we consider the standard of treatment. You want to do both isolated and humeral views, that is the elimination of the humerus or the glenoid, and then essentially assess your bone loss. There's a number of different methods, PICO method, etc., but I think you have to find what's best for you. Of course, we know the classic description by Burkhardt, we describe things as an inverted paraglenoid or the engaging Hill-Sachs lesion. And the inverted paraglenoid usually indicated at least 20 to 25% bone loss, where the engaging Hill-Sachs lesion meant that the humeral head fell off the anterior glenoid rim. Now, classically, though, you should know that the engaging Hill-Sachs lesion, as defined by Steve Burkhardt, is having the position of the arm in 90-90. Many times when we do an evaluation arthroscopically, it actually dislocates lower down and in a different position. But for Dr. Burkhardt, engaging Hill-Sachs means up here, 90-90, not down low. And he thought that was an important differentiation. Of course, now we use this so-called glenoid tract concept, where we try to know the relationship between the size of the Hill-Sachs lesion and the size of the glenoid defect, and that can actually help us sometimes determine what to do best with the Hill-Sachs lesion. This is of course brought up by Yamamoto, Itoi, and Burkhardt, but I think it's a good guide, but it doesn't always tell me exactly what to do. I think that preoperative patient selection is important. Traumatic unidirectional minimal bone lesion in a compliant patient. I think if you have a male contact athlete, particularly if they're young, there's an increased recurrence rate, so you might be thinking of doing something more than just an isolated Bankart type repair. Of course, you can use this as well. Pascal Boileau, of course, taught us about the Instability Severity Index score, where you do a number of things, including age, contact competitive sports, hyperlaxity, and of course the bone loss too. And if you have a number greater than 6, what he noted that with an isolated Bankart repair, he had a 70% recurrence rate, which is extremely high. And he suggested that these patients, of course, should undergo a Latarjet type of reconstruction. And tomorrow we're going to talk a little bit more about bone loss and how to reconstruct the glenoid. So we'll see a little bit about that today as well. So this is what I think about today now. I think I have an a la carte approach, that not all patients get the same procedure every single time. I like to divide it up into the bone loss as well as what type of athlete I'm dealing with. I almost, in my practice, never do an isolated Bankart repair. If we do, I don't know how many instabilities we do a year, but it's probably close to 60 or 70. I would say maybe 1 or 2 are isolated Bankart repairs. The rest are some sort of advanced reconstructive procedure. And I think that's not to say that an isolated Bankart repair doesn't work. It's just that you have to understand what type of patients and what type of patient population you're dealing with. I think that's actually the most important thing. It's just because of where we are and where we live, many of our patients have, significant bone loss, etc. So to optimize things, I think patient positioning is important. I do think you pretty much should do most of your instabilities in the lateral decubitus position. While a beach chair position is possible, I do think it's more difficult to get posteriorly and to do some of the other techniques as well. It's also easier for the assistant to apply translational loads posteriorly and anteriorly. So I actually stand at the head of the bed here, and where the assistants are all down below, so we can look down into the inferior aspect of the glenoid. The portals we utilize are standard twin anterior portal approach. The most important thing really is this anterior superior lateral portal, which is created off the anterior lateral corner of the acromion. Everybody makes the standard anterior inferior portal, which we do just above the subscapularis, but it's really this one here, which is just in front of the supraspinatus, but posterior to the biceps tendon. That's the most important portal. And we use that portal actually not so much to do a lot of manipulation, but it's really the viewing portal. Lots of people do lateral decubitus position but view from the posterior portal, but I think that decreases all the advantages of the lateral decubitus position. You can see when you look to the anterior superior lateral portal, you can see anteriorly, but you can also see, most importantly, posteriorly as well. So you can see your Hill-Sachs lesions, the interactions, the sizes, and whether you have to do anything posteriorly to tighten things up as well. Of course, we must mobilize the labrum. I remember when we first started these, we didn't do very much of a mobilization, and if you talk to guys like Jimmy Andrews, they would do a very, very small mobilization and just attach it in situ and do a very, very minimal, if anything, shift. But we know now that to get a good shift, you of course have to be able to see the subscapularis, muscle belly behind it, and it has to be able to float to the same level of the glenoid with no tension. Beware, of course, when you're starting to do these, is that for the most part, I would say many of our lesions extend beyond the 6 o'clock position and extend into the 7 o'clock posteriorly as well. So you have to be able to release all the way around the corner. And what you'll find is a lot of your Bankart lesions aren't Bankart lesions, but more shaped like a J or shaped like a horseshoe or a U as they come all the way around the corner. It's a funny thing, like many times you'll have an anterior tear and a posterior tear, and right at that 6 o'clock position, actually it's a little bit intact. And you actually have to make sure you take all that down and mobilize it so that whole thing can be lifted up. Of course, you can decorticate the bone as well. Some people are extremely aggressive as far as taking off cartilage in that area. I tend not to do that. I preserve most of the bone and most of the cartilage as well. Anchor insertion, I think honestly, you can do anything you want. There's knotless techniques, knotted techniques, hard anchors and soft anchors. The most important thing, honestly, is making sure you get the anchor where you want to get the anchor and getting the sutures where they're supposed to go. The rest, the technology can help us in that fashion. So how do we do that? If you're going anteriorly, I almost always use a trans-subscapularis 5 o'clock portal, as you can see here. That's through a standard anterior-inferior portal. This is through a trans-subscapularis 5 o'clock portal. You can pretty much get to the same position, but you see how oblique the anterior-inferior portal is, and so I tend to do trans-subscapularis approaches. Of course, if you have curved guys, this can help you as well. Usually, if you want to do a trans-subscapularis, you just do percutaneous through the skin. You don't have to establish a cannula per se. However, if you actually want to get super low down, right down to that 6 o'clock position, the easiest thing to do is actually come from the back. And so when you come from the back, you're actually going to use a 7 o'clock portal to make a 6 o'clock anchor. So you can see here, we can make this 7 o'clock portal, and you can access more posteriorly where you want to go to. And in fact, you want to basically put it at the very bottom of the 6 o'clock position. You use your sheath, you lever the head forward, and this is the very, very first anchor you put in, because this is the hardest one to put in, and you actually want the head subluxed anteriorly to make it easier for you to put that anchor in. As far as suture passage is concerned, I think when you're low down, using a hook type instrument can be extremely useful. As you can see here, when you're doing this actually to get low down, you don't usually work from an anterior portal, you're usually working from a posterior portal using the opposite needle. So in a right strul, you're going to be using a left hook from the posterior portal. But the other thing you can do as well is you can use an antegrade suture passing instrument. So many times if I'm working anteriorly, I'll use a first pass or an elite pass or something like that. And what you want to do there is you can get your instrument, you put the lower jaw through the labrum bone interface, and you walk it all the way down, and you can see here how you can pass actually low down even with an antegrade suture passing device there. So in the final repair, honestly, can that play? Is it possible to play that? Yeah. Oh, great, sir. This is how a repair used to kind of look, where you can see this is a Bankart repair and it goes all the way straight down. And I think that's okay, but this is what I call a straight repair. But most of the time that means you haven't maybe tightened things up directly 6 o'clock inferiorly. So you can see a lot of our repairs now go like this. They go all the way around the corner for that J or horseshoe type repair. And that's really what we're trying to look for nowadays. What about Hagel lesions? Hagel lesions are actually much more common than you think. I think if you particularly only look from a posterior portal, you can miss a lot of these. Some of these can be isolated lesions. Other of these can be combined with Bankart lesions. You can see Hagel lesions or even reverse Hagel lesions and anterior instability. And honestly, just kind of depends on the pattern of how they dislocated. These can be difficult to repair arthroscopically, especially from an anterior Hagel approach, but it is possible. The hardest thing really to do is get your anchors in, and if you're interested, we can talk about that a little bit later as well. Oh, I guess we're going to talk about it. Okay. So here's a Hagel lesion. This is from a front portal. This is a right shoulder. You can see how the capsule has been torn off the humeral head. That's the reduction maneuver. Essentially, you're going to use a 30 but also a 70-degree arthroscope to make sure you can look all the way underneath the humeral neck as well. And then it's the trans-subscapularis portal, which is the most difficult thing to do because there's a tendency always to kind of fall off the head. So we call that the so-called killer angle. And you basically want to go as low and as medial as you can and aim laterally. You can internally rotate as well to increase the angle. Once you get your anchors in, honestly, it's a lot easier. You can just use your standard suture passage. You can use an antegrade, or sometimes a hook and type instrument from the posterior portal can work as well, just to repair the lesion. Bone loss, I think bone loss is extremely common. We see glenoid bone loss almost all the time. You know, when Sugaya did his study, 90% of patients had some degree of bone loss with recurrent anterior instability. There's lots of options out there for you. And so this is the option. Well, we're going to talk a little bit about this tomorrow. I don't know, do you want to keep talking or should we just stop here? Just a little bit? Okay, so we do a bit of distal tibial allografting stuff now. We used to do this open. Ivan Wong was the first actually to talk about this arthroscopically. Ivan is one of our surgeons in Canada as well. He's kind of on the East Coast in Halifax. But now we've kind of evolved to this suture button type fixation. This was of course not developed by me, but developed by Dr. Boileau, who taught it to me with the Latarjet reconstruction. But now we've evolved this for double button fixation using a bone block technique, which I think is somewhat safer and somewhat more anatomic in nature. And so, can we hit play? Thank you. This is just an example. We're going to talk a little bit more about how to do this tomorrow and what our early results are. But you can see the advantage of this is that you can actually drill from posteriorly, so you don't have to do anything manipulation anteriorly or trans-subscapularis. You do parallel drill holes. This is actually a guided technique, which makes it actually relatively reproducible. And so finally, when you make your drill holes, the drill holes are essentially 5 millimeters deep to the articular surface. And then you can pass your graft using sutures. And so you don't actually have to have a straight line approach. That way you can actually bring it down through the rotator interval. It'll turn the corner and come against the face of the glenoid. And so you can see it on the outside here. This is actually one of our older ones where we did a bone block technique and we had no cartilage on the area, but nowadays we use cartilage for alignment. And you can see how you can line it up cortex to cortex. You can tie it down. It's an amazing thing because you would think that the sutures will not provide enough compression, but they actually provide excellent compression. It's actually the shear you have to worry about a little bit more, which we can talk about tomorrow. But it's actually, that's why it's critically important, I believe, that when you do one of these bone block techniques with suture button fixation, you must fix the Bankert lesion on top, which shifts the head posteriorly, so you'll decrease your shear on the graft. I think that if you have significant amount of soft tissue loss anteriorly, you can't do that, then I think you're looking at a Latarjet, because I think a DTA would be at risk. So the rehabilitation is pretty standard. We do 4 weeks in a sling and then progress people up from there. You know, we always talk about return to sport at 6 months, which I think is totally hilarious, because, you know, I think that you can take your time. Unless you're a professional athlete and you need to get back next season because it's a contract year and you're willing to take that risk, I think you should strengthen and you know, do a lot more advanced sport-specific training before you jump into injuring yourself again. I mean, I just had a kid come into the clinic who had his surgery done at the Mayo Clinic, and he started playing hockey 6 months after surgery. 2 weeks later, he dislocated his shoulder again. So it's kind of like, and I actually told him not to go back to play, but he couldn't help himself. And it's because I was like, you feel a little bit weak, I don't know. He's like, it's a big year for me, because next year he's going to get drafted. I was like, okay, but I think this is a bad decision. And you know, 2 weeks later, re-dislocated his shoulder, so he's probably looking at a Latarjet somewhere down the road. So if you do modern techniques and make sure, you know, I don't know if it's really modern techniques. I think our technique has improved quite a bit, but I think it's really modern indications of a Bankert repair. who actually do we do a Bankert repair in. Contact athletes still has a higher recurrence rate, but if you're very careful as far as lateral decubus position, 3 anchors minimum with minimal bone loss, you can actually get a relatively acceptable recurrence rate according to this meta-analysis. Oh, but that's Tim. So he's another Canadian as well. So in conclusion, I do think patient selection is the #1 most important thing. You make sure that you're doing the right procedure for the right patient. In my practice, I almost never do an isolated Bankert repair. I try to treat all the pathology at hand. Thank you very much. Questions? Are there any questions? Oh, yes. Versus another piece of bone? Yeah, I don't know if there is a major benefit. I do find that the alignment of the bone graft is somewhat easier with the arthroscopically. I could just see it better. I find it easier. I find it easier. Actually, I know that sounds crazy. You think I'm crazy? Yeah, I actually find it, you know, when I trained, we did do open surgery, of course, but when I came back to practice about 20 years ago, I would say that 95% of my practice was arthroscopic. And so when somebody tells me to do like maybe an open Bankert repair, I'm like, oh. So I send that to my open colleagues. So that's what I would do. And I still, we still do some open instabilities. Like we'll still do open lateral J's because I think that's just much more, predictable. And they're, you know, it's like this is the be all and end all. You better get it right or you're totally screwed. But I find that the view I get from the top for alignment is very good. And then when you're doing the an open bone block technique, I find the visualization difficult unless you take down the subscapularis. And so I don't like that as much. Where I can do because I take the coracoid down, when we do a lateral J, I can easily do that through a subscap split. It's super easy to see, but when we're doing an open DTA, I find it more difficult. Yeah. The same thing posteriorly, you know, like a posterior bone graft is super easy, well, never say super easy, but easier arthroscopically, I believe, than open, yeah. Yes.
We all know that when we have a Bankert repair that fails, we have many things that we can do, but what we can do when you have a lateral J?
Yeah, I agree. That's horrible. So that is one of the reasons why we have been looking at other options and other options we can do. So one option when a lateral J fails, I mean, it does depend on where the screws are and where the coracoid is obviously doing a distal tibial allograft. That's usually the next step. And so, or some sort of bone block procedure, I'm sorry. Some sort, you can choose whatever, iliac crest, doesn't really matter. Some sort of bone block procedure. And particularly if somebody has done an open lateral J, I think the arthroscopic procedure is actually somewhat more easier, especially since you don't have to deal with the subscap or anything like that. Just go through the rotator interval. I think that's, I mean, we love the lateral J. It's an awesome procedure, and when it works, it's amazing. But when it doesn't work, it's a disaster. And I'm sure, I don't know, I do. I have lateral J's that became absolute disasters. And I know that, you know, if we did something different, it wouldn't have probably have been a disaster. So lateral J is awesome, it's just its complications can be catastrophic. Do you, what would you like to do, Louis? Do you want to do something there, or do you want to do another talk, or? Okay, sure. Oh, I heard that. There was a request for translation.
Yeah.
Request for translation.
We have the solution. Don't worry.
Okay, okay.
Okay. Él estaba comentando que parte de su presentación, aquí están los materiales. Él trabaja con la marca Smith & Nephew. Aquí vamos a ver anclas como Suture Fix, que es una ancla de núcleo de sutura. Van a tener BioRaptor Knotless, que es una ancla de Peak Knotless también para inestabilidad. Y vamos a estar viendo también otros tipos de anclas. No.
Okay. So, very good. So, this is just the suture fix, and it's a very small. It's 1.7.
Yeah.
1.7 millimeters, and you can see that it's an all suture anchor, and so it's a soft anchor essentially, and it's single loaded.
Okay, no. Está diciendo que es una ancla de sutura, es de 1.7 y va a venir con una sola sutura, o sea, 2 cabos de sutura.
Is that it?
Okay?
Is that
Yeah.
the sheath?
No?
And so
Okay.
that's what we were talking about with the sheath. You know, when you want to get low down, and suppose this is the 6 o'clock position, right? And I'm looking at a right shoulder, so it's like this. So this is anterior and this is posterior. So if you need to get an anchor down low, and you're from the front, from the anterior inferior cannula, you cannot get down low.
I'm good, boy.
You're good, yeah. You
Ok, él va a hacer, digamos, la demostración como si estuviera a las 6 de la tarde. Estamos en que esto es anterior, esto es posterior y que, claro, pensando que tenemos el paciente en todo lateral, no va a ser así tan facilito como lo vemos en el bloquecito. Okay, now
And
go.
so to get to the 6 o'clock position, it's easier to go from the back. And so, okay, go ahead.
Para llegar a la posición de la 6, es preferible irnos desde atrás.
And so instead, we take this cannula. Now we use now the humerus is here now.
El húmero está ahí.
So because it's anterior instability, when you use your traction, it will pull it this way.
Como estamos trabajando con esta inestabilidad anterior, al jalar, la cabeza del húmero se va a desplazar.
As
Para
well,
darlo,
if you externally rotate like this,
vamos a rotar externamente.
the flattened humeral head will actually give you better access to the 6 o'clock position.
Y eso va a hacer que tengan mejor acceso a las 6.
So traction and external rotation, and it'll sublux it like this. If it dislocates, it's even better. Because there's no
Tracción y
head in the
rotación
way.
externa para poder abrir
Dice
el
que si
espacio.
se disloca,
Y
es
si
hasta
se
aún mejor.
desloca, está mejor todavía.
So this is the first anchor you put in.
Esa es la primera ancla que vamos a colocar.
And then you use a needle from the post. So if this is the acromion now, posterior lateral corner of the acromion, it's about 4 centimeters off and towards straight down.
Okay, vamos a tener una aguja, vamos a tener el espacio supracromial y vamos a estar a 4 milímetros de ese espacio.
And so then you can follow it up with your sheath, and then once you get this, you put it on the cartilage. You use a mallet, and you have to make sure that you are on the bone, because if there's cartilage there and you go, it'll slip off. So you have to tap it a little bit, hit the bone as you're hitting the bone. If the humerus is here, you go and you push the humerus over. Because a lot of times when you do that, you'll be like, ugh, the angle's not so good. But as someone's going tap 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 tap, and you increase the angle to lever the head over, push it over. Does that make sense?
Yeah.
Ya.
Good.
Okay,
And then
let
you
me
drill.
remember. Okay.
Okay.
Va a colocar la guía.
I don't
Ya
drill.
va. Y la idea es que estén en cartílago, okay, y que puedan golpear un poquito para colocar la gana. Luego. Okay. I'm skinny, but
Yeah,
I'm
you know.
strong.
You push it?
No.
There we go.
Okay. Y
So your job as the surgeon, if you were the surgeon, all you do is hold this. somebody else should be drilling and somebody else should be putting the anchor in, because that's the easy part.
Tradúcele eso.
Okay.
Si tú eres cirujano, solamente tu trabajo es agarrar.
Agarrar.
Más nada.
Va a haber otro que les va a martillar, va a quitar, poner, abrir el agujero.
La parte más fácil, lo que digo.
Lo más difícil.
Push it up.
Yes. See, yeah. Yeah, so the surgeon, you're standing here at the head of the bed, you do this, and then somebody else, an assistant or a nurse or another doctor, does all this other stuff, and then you take it off. Because this is, the holding of this is the most important thing.
El tomar la cánula y o sea, la guía es lo más importante. Que va a haber otro personal encargado de abrir los agujeros, pasar, quitar, etc. Para que ustedes se puedan concentrar en sujetar la guía.
Una pregunta, él dijo que él siempre normalmente opera en decúbito lateral, pero la mayoría de aquí operamos en silla de playa, en beach chair. Esa salvedad.
¿Cuál es tu pregunta?
No, la pregunta es que trate de si él se adecuarnos a como nosotros. Sí. Si usted lo hace también, if you do.
Es que le decía.
Because the 90% of us operate in beach chair position. We don't use, you don't use light
So
position here.
it's possible to do this in the beach chair position. But usually what you have to do, instead of sitting up straight, you lie them down a little bit and you have the arm pulled forward like that.
Acuesta un
We don't
poquito.
use here.
Mira, y tracciona.
Sí, lo dice, hacia abajo.
La idea es luxar, tratar de luxar.
Subluxar, ¿verdad? Subluxar.
Y abduce y lo saca. Y vas a tener entonces la vista superior.
No se subluxa, uno nunca llega a luxación, sino subluxa.
No es una solución, ¿no?
Es una subluxación.
Solución. Y se
Well,
relaja mucho mejor.
It's difficult, but probably the best thing to do if you are not familiar with lateral decubus position is to go to a course sponsored by Smith and Nephew. Because you'll find it's a little bit different to learn, but then when you go back to the hospital, try to choose cases that are very easy to do in the lateral decubus position. You know, maybe just removal of loose bodies or something like that, to get used to the positioning or something like, or maybe capsular release or biceps tenotomy or subacromial decompression, and just practice easy cases in lateral decubus position, and you know that you can do that probably, and then slowly migrate to instability and rotator cuff and all those other things. Does that make sense?
Yeah.
That's what I would do. And in actuality, this sounds crazy. I think a good instability operation is a very difficult surgery. A rotator cuff repair, arthroscopically, it's actually very easy. It's simple. But when we teach people, especially residents, we teach them to do instability first and rotator cuff second. But it's actually wrong. You should teach rotator cuff. I teach the residents to fix a rotator, and the fellows to teach a rotator cuff first. Rotator cuff first, subscap first, that stuff is very easy actually. But to do this is much more difficult. Low down, posterior, everything is starting to swell. So maybe you even choose to do some easy rotator cuffs in the lateral decubus position. 2 centimeter rotator cuff tear, right? That's super easy, and then you slowly migrate to this.
Sí. Hay
O sea, lo que
practicar el
recomienda
decúbito
él es
lateral.
definitivamente
Es que,
entrenarse en decúbito lateral,
es que de
pero
hecho,
ir
hasta los
migrando
cirujanos
desde
que
casos
todo
más
el
sencillos
tiempo
a los más complejos
operaron
para que
en
puedan
silla
ir
de playa.
aprendiendo la curva de aprendizaje.
No, trae más complicaciones en silla de playa, totalmente. De hecho, ahora los especialistas están cambiando de decúbito lateral. En todas partes puedes hacer los cursos a toda edad.
So once you put the low anchor in, and this one is single loaded, but it's
This one and this one.
El recuperador es
yes. And so you know, this is one of the things about ladder decubitus. When you're looking from the top, you can work from the front and the back. And so now we want to grab the inferior capsule. So if you want to do this from the front, it's actually very difficult. So you actually do it from the back, and you come with the hook from the posterior aspect. I don't even know if this will go through.
No hay una más angular.
Wow.
No, es que normalmente es por
Some
este
very
tipo
good
de
tissue.
material.
Very good tissue. And then you can just, you know, shuttle your suture back through. Can you put that in there? Yeah, because I'm very lazy. And you can do the same thing. Usually when I do this with a double loaded anchor. So actually I use Q-Fix.
1.9.
I use Q-Fix.
Ah, ok. Él utiliza
Q-Fix.
otra que tiene también Smith
Which is
Nephew,
another soft
Q-Fix.
anchor.
que viene con doble sutura.
And then you can, because that way you can take one in the front and one in the back and go
Claro.
Sino que puede tomar
decrease the volume of the axillary recess. So one in the front, one in the back, and then you can tie that, and then you can work from the front.
Lo que hace
That
es
makes
anudar
sense?
y luego va a trabajar hacia anterior.
So the same thing, let's put one in the front here.
Okay. You want another sheet
Where's
to
the
fix?
drill? Yeah. Where's the sheet? Here it is. Okay. So now you're working from the front. Let's say
Ahora
you do.
vamos a trabajar en anterior. Sorry. I forgot.
Coloca la sede de la carga, pero no la anuda todavía, ¿no?
Where's the note?
So when she's pulling back there, that's actually providing a force. Is it 50 newtons? Can't remember. And so once you do that, you get a front. Now you can, in this particular case, you can use the opposite hook. Was that right? Oh yeah.
No.
Yeah, you can use the opposite hook from here, but actually what I find easier, because you're working from the front, is you can use your, you don't have a needle.
No.
But anyways, you can use an anti-grade device like this.
Okay. Wait, there. Fíjense, para este utilizó con la punta hacia la izquierda. Él dice que para acá pudiera utilizar con la punta hacia la derecha, que pudiera ser más cómodo, pero en que él prefiere utilizar este tipo de pinzas, la First Pass. Lo que pasa es que no nos llegó la aguja, pero sí la vamos a tener aquí.
And the advantages of this is that you don't have to shuttle, but when you go like this, what happens if you make a good big mobilization, you put the lower jaw into it at about the 3 or 4 o'clock position, and then you can just slowly walk it down, and you can usually walk it all the way down to the very bottom.
Lo que hace es, lo coloca y va como deslizándose con la punta de la pinza, ¿ok? Hasta que llega a la posición donde quiere estar.
Agarra el ligamento. Pregunta.
Sí.
Agarra el ligamento.
¿The
Yeah,
ligament?
the labrum ligamentous capsule, yeah.
Okay,
The whole
sí.
sling, yeah.
Ligamento
Lo
capsule.
aplica.
Yeah, and so because you see the difference is this: when you use a hook instrument is a pull instrument. You actually have to pull it back towards yourself to get the needle through. If you push, it's going to keep, and it will never come back. So you actually can't get that low with a push like this instrument where you have to pull back. Where this is a push instrument, you can push all the way down. And so you can actually get lower with this than you can with the hooks.
Okay. La diferencia es que este es un instrumento para jalar y por mucho que puedas ir hacia abajo no vas a llegar tan abajo como puedes hacer con un instrumento que es para empujar. Entonces esto les permite llegar mucho más abajo de lo que pudieran hacer con este instrumento.
I mean, there are other tricks you can use as well. You can put a traction stitch through here and pull it up.
También pueden poner un punto de tracción y poder jalar.
Or obviously you can also work from the back as well some.
O también trabajar desde posterior para poder tener acceso. Exactamente, con el agujas.
And then you just repeat.
Y luego repetimos.
Usually for us, we have 3, maybe 4, something like that. Depends on the.
3, 4 anchors?
Yeah, but they're all double loaded, not single loaded.
Ok, normalmente pone de 3 a 4 anclajes con doble sutura.
Pregúntale cuándo anuda esta, por favor.
When you knot this one.
Anuda.
When do I not tie
Yeah.
it?
Tie it.
That's such a they're very smart. That's very smart because if you tie this too early, and this shifts, especially if it's double loaded, then you shift this up and then you shift this up like this. It is sometimes hard to get back here. So we don't tie yet. We put this anchor in and pass the sutures. No tie. This anchor in, pass the sutures. Come back and tie.
O sea, él coloca esta, hace el pasaje de las suturas por el tejido, coloca esta otra, hace el pasaje por él y regresa aquí para anudar esta.
Bien.
Si lo hace antes,
No ve, no va a ver. Ahora, él trabaja por el portal antero superior, esta, según entiendo. Cuando trabajas con esa.
This one?
Con esta.
This is through an anterior inferior portal. I'm
Anterior
viewing through an anterior superior portal.
Ve por el anterior superior
Así.
y trabaja por el anterior inferior.
Ya, con esa.
And when you do heel sack, how many anchors do you use for heel sack? 1 or 2?
Almost always 2.
Always 2.
Sometimes 3, but usually 2. 2 double-loaded anchors. They're usually glenoid anchors. I don't use humeral anchors usually because the bone is usually quite hard, and so I use 2 glenoid anchors, and they're double-loaded. And okay.
O sea, para heel sack, él usa normalmente 2 anclas, que sean anclas de glenoide. Pero
Ok.
que estén con doble sutura.
My humerus.
Bueno, pero depende del defecto, ¿no?
Todo lo más, sí.
Do you have a pen?
Quizás me quedo
Un marcador, lapicero, esfero.
Okay, so let's suppose we come in here, and then we say the large Hill-Sachs lesion, and it's out the front. So before you touch anything on the glenoid, you address the humerus because you want it to be dislocated and subluxed anteriorly to access the Hill-Sachs lesion. I make the call of whether I'm going to do a remplissage early in the surgery and before I touch the Bankert repair. So when it's subluxed anteriorly, there's lots of space to work posteriorly. And so the first thing we do is we go there and we debride down the Hill-Sachs lesion to a bleeding bone surface. Sometimes there's cartilage here. Oh, sorry, go ahead.
Okay, I'm like... Son las lesiones de heel sack. Prefiere primero trabajar el húmero para aprovechar todo el espacio y lo que hace es una buena resección. Hay veces que va a quedar cartílago ahí.
So sometimes there's still some cartilage left. Here, you have to take the cartilage off and make the bone bleed.
Él remueve todo el cartílago y hace que el hueso sangre.
It's very depressing.
Yeah.
Pregúntale que si el 22% de los daños que produjo, o sea que hay un 22% que no tuvo buenos resultados, que sí fue porque los huesos del peroné no soldaron cuando lo pusieron en la...
De la tibia.
De tibia, pero...
Pero
eso es la tarjeta.
Eso es la tarjeta cuando hay pérdida ósea.
Ajá, ya.
Pero él está hablando del ILSA.
De Hill-Sachs.
Está hablando, todavía no ha arreglado.
No hemos llegado.
O sea, está haciendo reemplazar.
Okay, so before you put the anchors in, I go into the subacromial space and I clean out the bursa all the way posteriorly so I can see everything in the infra and the teres all the way down.
Okay. Antes de colocar cualquier anclaje o hacer cualquier reparación, él se va al espacio subacromial y limpia todo, inclusive la bursa y todo, para hacer una buena remoción de tejido.
So now when you're putting your anchors in, you usually put one. This isn't a perfect Hill-Sachs lesion, actually. It's kind of wrong.
Y son grandes.
It's actually, but it's okay. You want to put one
kind of inferior and one superior.
La idea es poner un anclaje inferior y uno superior.
Pero ese
And it kind of should look more like this.
Dependiendo
But
del
it's sorry.
grande.
It's kind of not exactly right. And so, but the angle you come through here like this to make it perpendicular to the bone is very straight. Does that make sense to you? It can't be like this. It has to be like this.
Tiene que ser muy recto.
So it's very medial on the muscle of the infra and the teres. So when you put them in here, you're going to put it here, one here, and one here. I like to put it right against the articular surface.
Y una, o sea, ella bien contra la superficie
¿Le puedes
articular.
preguntar si en ese momento él quita un poco la rotación externa o la mantiene?
In that moment, the external rotation,
en lesión de Ilsa.
like,
Yeah, I can do. You can external or neutral, whatever makes me see easier. Sometimes it's too external and it's dislocated like this, so you have to pop it back into internal so you can see it.
Como que
Yeah,
va bien,
so
se tiene que liberar o no.
whatever gives you the straight shot. But if the problem is now the sutures come out this way, it's too medial. So I take my sutures and I use a little penetrating device like a Raven or something like that, and I make my sutures come out more laterally. So they're in the tendon and not the muscle belly. Does that make sense?
Okay. O sea, las suturas las pasa por el tendón y no, digamos, por el cinturón muscular.
Because I reroute them more laterally.
Sí, claro. Un dispositivo.
An arthro pierce or something like that. And so then I do a double pulley. So I have the sutures coming out through 4 different holes. And I don't tie yet. I leave that for later. Bank cut repair. After you do that, because now once you do the bank cut repair, the head is shifted back posteriorly, and so when you tie the tendon and the capsule down in the subacromial space, there's less tension. If it's like this and you want to tie it, it's like it's a lot of force for it to shift the head back.
Si no colocaste bien
O sea,
la
pasa
se
las
sale.
suturas, pero no la.
So that's why I do the bank cut repair first.
Hace
shift the
reparación de
head,
banca,
then
coloca
tie
de
it
nuevo
down.
la cabeza y ahí sí.
Y ahí sí, perfecto.
Because there was one time I tied it down and then it tore the knots tore right through, and then they were in the glenohumeral joint.
Le puedes
And with
preguntar
no
la
tendon.
última cosa. Plicatura a las 5, plicatura con buen ligamento, ¿lo toma en consideración?
Like if you, plicatura en inglés es
Plication?
plication. Yeah.
Yes.
Like in half, like at 5 o'clock, with a good ligament. What do you do?
If
Esa fue la
I,
pregunta. Sí.
if I want to do a plication at 5 o'clock
Yeah.
position,
Yeah.
what? Oh, how do I do it? Yeah, sure. It's same idea. If you want, it depends what type of suture pattern you would like to make. So if you're just doing a big grab, then you can just use this.
O sea, si es
Come down.
un tejido,
And this will go, if this is the labrum and the capsule, this takes a huge bite of the capsule as well.
si puedes tomar una buena mordida de cápsula, él recomienda este tipo de dispositivo.
If you want to do a pinch tuck technique,
Pero si es como apenas
like
una-
classic Steve Snyder, you have to use a hook.
Okay.
Yeah, you have to go back in and out and be that's classic Steve Snyder technique.
Okay, thank you.
Lo importante es que tenemos ambas. Tienen esta y tienen la copa.
Tengo las dos.
Did you just say?
Y todos los ángulos.
I think I know what you said.
A little commercial.
Ligamento. Es que tienes que agarrar el ligamento. Porque es que acuérdate que tú tienes, es que tienes que agarrar los dos. Pero el ligamento. Ella no habló del ligamento, no, ella le dijo.
Number
Ella
one
le dijo.
sport, right?
O sea, cuando tú agarras mejor el ligamento, tienes que agarrar el numeral medio, y que el numeral inferior es mucho más. Hay que agarrarlo. Entonces, normalmente lo agarras como así.
Oh, you're screwed. You're basically screwed.
What do you prefer? Because you can take out his hyperlaxity of that kind of activity.
Internal rotation, everything.
Yeah.
What do you bone block or?
Si tú
Oh, what do I?
Pero él
Okay, yeah.
mencionó algo que no comprendí.
You have to understand, in Canada,
Para colocar
we don't have many throwing athletes.
él lo pone
Our, yeah, you know the throwing athlete we have is curling.
y la y hace la
Yeah, I know, I just joking. So most of us are contact.
Pero eso,
And so a little bit of tightness
posterior,
is
claro, porque
okay.
está
I
hablando de
think
posterior.
though, in my
Pero
experience,
se puede hacer
using
anterior,
bone
porque
block
también está descrito en la técnica.
has less capsular tightness than a latarjet.
Que es en inestabilidad que se hace. Pero mucho más.
I mean, we haven't compared, like, you know, we don't have that many overhead athletes, but just judging from what I see, particularly in about 9 months to a year after, like the distal tibial allograft, they get their motion back very quickly, whereas the lateral J is still a little tight.
la doble sutura la utiliza en qué momento.
Menos rígido. Y que no pierda la
Yeah. Let's throw you better, a little bit loose than tight. Yeah.
Sasan.
Okay.
Doctor, thank you.
Thank you
Good.
very much.
Vamos a hacerle una a él. Ahora,
Bueno, en la tarde no sé si...
Bueno, si quieren también conocer más del material, tenemos de rodillas, también de hombro. Así que esta va a ser la caja instrumental que va a ir accediendo.
Pero tiene el de 4 suturas.
Esta es la Heliacol. Fíjate, el diseño es único porque es una Heliacol. ¿Cuál es la idea? Que el hueso crezca dentro de esa y tiene menos material. Tiene 4. Esta viene 4-5, viene doble. O sea, va a tener 4 KO, 4-5 y 5-5.
Que está bastante bien para el ICE, ya para atrás, pues para uno.
Tiene también
Es la normalidad que tiene.
esta es pupila. Esto es para hacer doble clic. Esta es la doble. Esta descarga es la sutura. También para inestabilidad. Sí, esa es la Super Fix de 1.7. También está la 1.9 que sí trae 2 suturas. Entonces van a tener todo este portafolio disponible para ustedes.
Casi siempre quedo de primero. ¿Qué tal me dijeron? Pero quitado. No, R3 ya va claro porque se vaya en una semana. Ya va a ver. Eso también les acabo. ¿Usted sabe quién está? Le van a alargar.
Yo le creo. However, if it's posterior, that makes no sense.
O sea, cuando tiene una lesión de King o algo.
Algo que yo te voy a decir, que él lo dijo, pero que no lo hiciste. Es lo siguiente. Ahora yo estaba hablando ¿sabes? Cuando se opera inestabilidad, yo no podía operar inestabilidad, pero no lo que más operaba era inestabilidad. Cuando se opera inestabilidad, él dice que él pasa, él transfixa.
la mitad de la... Entonces beneficia a él porque tiene que pagar menos.
Entonces, decir, tú transfixa a través de los músculos y después la...
Making a point.
No, imposible.
That's good. Don't you do that cross? Yeah, the cross.
alta con una reconstrucción en una
Que después.
una me va a bloquear el contexto de la rotación.
Centímetros más o menos, bastante.
¿Con la rotación o si el bostezo y la rotación? Doble banda.
Con euros.
Vamos a hacer con un solo implante.
Una pregunta dentro de las rodillas, sobre la dieta reconstructiva. Por ejemplo, en su última
muy poco cuando se usa el isquiotibial, pero es peligroso que quede un intercóndilo cerrado, porque tiene un índice de falla mayor. Yo prefiero perder un poquito de tiempo y hacer unas plastias un poquitito más grandes y asegurarme después
déjalo bien libre,
poder ver bien dónde voy a hacer el túnel. Prefiero ampliar un poquitito las distancias. La tendencia, el cirujano como va rápido y no quiere perder tiempo ahí.
Tú sabes que nosotros allá tenemos que comprarnos nuestras cajas.
No hay problema, listo, dale,
Doctor, muchísimas gracias.
por favor.
se hace.
Déjame buscar.
De hecho, yo hacerla tiene que ser algo muy proceso, o sea, algo que se vea, hacerle un microfiltro, que se vea que va a tener un contacto muy fuerte, porque no la tengo.
Pero hay que hacer un poquito, sobre todo hay dos lugares donde se hace la noche. Uno es el intercóndilo propiamente dicho y otra cosa es el techo. ¿Sí? Tenemos notchplastia y tenemos roofplastia, o sea, techoplastia. Si solamente hacemos un poquito de pared lateral pero no hacemos techo,
a veces tenemos problemas de impincho.
Termina con lo que le llaman síndrome del cíclops.
El cíclops es cuando queda una unión tibial y eso toca contra la noche.
Exacto, no, yo tengo pacientes así con chasquido, que cuando investigo, bueno.
Hay que hacer un poquito.
Yo uso y para los multiligamento también el tendón grande, a veces